good enough?
It is. Okay, so welcome to Hernia Patient Support Group and to our live chat. We get to ask a surgeon. I'm Jackie and I'm one of the admins of the group, and I'm delighted tonight to be able to introduce you to Dr. Ralph Lawrence from Germany, who's here tonight to talk to us about inguinal hernia. So welcome, Ralph. It's lovely of you to join us, and we're really pleased to welcome you here tonight and for you to give up your time. So do you want to introduce yourself kindly?
Yes, thank you so much, Jackie. It was nice meeting you in Prague. And of course, I have beautiful memories. And of course, on this place, the idea develops that we should have a debate on inguinal topics. And so might be I will introduce myself with a short presentation. I will give you some introduction to, I think, major topics regarding inguinal hernias. It will last around about 10-15 minutes. And I start with this slide. It's not just a hernia. And for that reason, I will, everything is visible, yes?
Yes, yep.
Perfect. And secondly, of course, so I'm in a private practice in Berlin, in Germany, which is a dedicated hernia center. Secondly, I'm a consultant surgeon at one small hospital with an own department on hernia surgery, which is the Hafe Clinic nearby. And the third position, I'm a guest scientist in the University of Brandenburg since almost 5 years, and I have a close connection to the Charité University in Berlin as well. I'm since 2011 the vice president of the German Hernia Society, and from 2017 to 2022, I was a board member in the EHS as secretary of the national chapters. So I will come up in my presentation about the therapy, when and how, and my own favorite is tailoring. Why should we do a tailored concept, or why should we follow a tailored concept? The indication for an operation should be only done if symptoms and the hernia diagnosis fit together. That is the most crucial thing, because sometimes there is rumor about hidden hernias and something like this. And in my mind, there must be a clear hernia diagnosis and the fitting symptoms. We have definitely hernia-related typical symptoms: pulling pressure only on exertion, a reducible bulge in typical places, and we have atypical symptoms, and they have nothing to do with a hernia. Pain at rest, pain at night, pain after exertion, pain after injuries, and numbness in the leg has nothing to do with a hernia. And the major intention to do an operation is, of course, the risk of an incarceration. And we should clarify, it's a very rare condition to get an incarceration or a non-reducible hernia. We have around about 3% of inguinal hernias with an emergency, but only 0.3% have a connection with the intestine. So it's definitely a rare condition. And sometimes a watchful waiting strategy is allowed, not in female, but in male. I come later to this topic. And when we do the examinations and the diagnosis, we should look for the medical history. We should look for a pain history. We should make a clinical examination of the groin, but not only on the groin, also on the muscles and tendons, the organs nearby, in the pelvis, in the column. And finally, of course, we have the sonography as a major possibility to do the diagnosis. Sometimes a CT scan or an MRI, but I think it's much more expensive and you don't need it for a regular case. When we look for the possibilities of a tailored concept, we include different options to treat. And always there should be offered an open non-mesh repair, an open mesh repair, and thirdly, an endoscopic repair. All these techniques have pros and cons. We have an update of the guidelines since 2023, and that is published. Everybody can have access to this update of the International Hernia Search Guidelines. And I was responsible for two chapters, finally, for the question mesh or non-mesh. And we came to the conclusion with my colleagues, David Chen, Mark Miseres, and Heiko Wiesner from Germany, that mesh-based techniques are recommended for the majority, but not for everybody. Non-mesh-based techniques can be suggested in selected patients after shared decision if the expertise is available, and the shoulder seems to be the best evaluated technique for a pure tissue. We have open preperineal techniques, which seems to be acceptable and in the same, at least equal results as a Liechtenstein repair. There are some pros for this technique as well. Something which is definitely also new, laparoendoscopic. For the patients with primary unilateral inguinal hernias, the endoscopic technique seems to be recommended regarding the reduction of chronic pain. But however, there are patients and characteristics that would favor an open repair. We have definitely not a best technique for all inguinal hernias. We have a lot of different techniques right now, and we have the open preperineal techniques, we have the Liechtenstein repair, we have a lot of open techniques without many mesh, and we have right now a lot of endoscopic repairs. There is definitely a trend even more for endoscopic repairs. There's right now in US and might be in different countries a trend for robotic repairs, also for inguinal hernias. But we have to start with the Liechtenstein, which is the most common technique worldwide. And this Irving Liechtenstein was famous not only for his technique, he was famous for the concept of tension-free repairs, for one-day surgery, and the repair under local anesthesia. The two other topics might be even a bit forgotten right now, but they are really important. I think most of the cases could be done as a day case. The open preperineal techniques are putting a mesh from the open access to a placement of the mesh which is retromuscular, and it seems to be right now that the results are equal or even better. There are different options, different techniques. I want to not to go into more details, but we have different options. And finally, of course, I would come up to one of my favorites. Shoulder technique is something which is famous since a lot of years. And right now, we can look back on a history of more than 500,000 operations. And annually, in the Shouldice Hospital in Thornville in Canada, they do 5,000 cases each year, not in a decade like in other countries, or even it's something in my mind which has a really, I think, double-checked complication rate, which is very low, infect rate recurrence rate very low. And there are a lot of actual or current studies on this topic, which is definitely might be very interesting. And it's in the opinion of the Shoedice Hospital, not only for selected cases, for the majority of cases in their hospital. I'm a bit more open to different options, and so I favored it for selected patients. I will come back later on this. We have a third technique, which is more and more interesting, the disorder repair from India. It looks like right now that is a very good alternative. The repair seems to be easy and quick, and the recovery is always very good. And we have right now a lot of reviews and meta-analysis comparing the disorder technique with Liechtenstein, and they seem to be equal. We have a huge variety of patients, and we should keep this in mind when we accept a tailored concept. And we have, I think, always the hernias look similar on the first view, but they are fundamentally different. We have different hernia types. We have different hernia sizes. We have different hernia risk factors, different ages, BMI, comorbidities, previous operations, patients' activities and exertions. And one technique doesn't fit all, definitely not. So we have, and when we debate about I think the ideal indications for the big groups of patients, we have to ask who has the highest risk for complications, who has the highest risk for recurrences, that's almost direct hernias, and who has the highest risk for chronic pain. These are even more the young patients with small hernias. And that is the ideal indication for a pure tissue repair. So in summary or in conclusion, the open tissue is something for young patients with small hernias, and if they, of course, have any concerns against foreign bodies. The open mesh repairs are something for older or huge hernia, or even expected visceral adhesions, and the endoscopic repairs are ideal for obese patients, femoral hernias, and bilateral hernias. So there is, since 2003, and might be it's today always forgotten, a navigation for tailoring, which gives us a bit of guidance. And the gender has an impact, the age has an impact, the hernia has an impact. Is it a primary or is it a secondary? The size of the hernia, the localization, smoking has an impact. Is there a family of background? Is there any collagen disorder? And finally, a summary, not the points, makes, I think, or matters so much, but of course you get in the influence what is the best technique for your patient. We have finally some emotional evidence, and that is something which is definitely new. We have something, or we have heard something about mesh complications. We have something heard about mesh and visceral complications. Mesh and prostatectomy seems to be an issue. The certain preference, the mesh allergies. And finally, of course, I want to talk about sustainability and the environment and the environmental impact. Of course, there are a lot of publications in the last 10 or 20 years about, of course, mesh pain, mesh-related pain, migration, shrinking, meshomas, degradation, dysarticulation, and we have a lot of mesh explants after years also. Visceral complications seems to be more frequent after endoscopic repairs because of the close contact of the mesh to the viscera and the closing defects and inflammatory reaction. We have a problem which is definitely written by the urologists, because when we do a surgery after a bilateral hernia with mesh endoscopically, then the previous or the operation time seems to be much more complicated. And the most important thing is the less adequate lymph node dissection of almost 70%. And that is a nightmare for any prostate cancer after a bilateral hernia. The bladder perforation, the peritoneal perforation might be also an issue, but I think the less adequate lymph node dissection in the topic of a cancer is something which is definitely a huge impact. We have, of course, our surveys about the surgeon's preference. And when we ask them, what is your favorite technique? Of course, we get definitely a different answer. We have asked a couple of times our young surgeons, and normally a lot of young surgeons wish to be fixed for their own hernia without any mesh. And the problem is, of course, the education for this. We have something which is new since 2018, the so-called mesh implant illness, which is an or autoimmune syndrome, which is related or could be related to a foreign body. There are some unspecific symptoms due to a chronic inflammatory process, and that is something which is new and on a lot of debates right now. Finally, of course, my last slides are something about sustainability, and one of these slides is very provocant because surgery is really a huge contributor to the climate crisis. Nobody knows this, and we can't ignore it. And we should have to reduce our amount of waste during surgery and something like this. And finally, of course, I have these beautiful slide for, of course, if you have done an operation which is not necessary, or you avoid any operation which is definitely not necessary because the symptoms are fitting not to a hernia operation, then it's I think the rate of an open tissue without any, of course, in local anesthesia is something which is definitely a very low limit level. But robotic seems to be something which has a lot of waste, uses a lot of energy, and finally, of course, so this grading is a bit provocant, but of course, it should open our eyes. And if you could decide as a patient what is for you the best technique, that might has an impact also for the future. So finally, in conclusion, we have a lot of differences for the hernias, and the ideal technique doesn't exist. All techniques have pros and cons, and an ideal indication in my mind. We need even more clear defined operation standards, a tailoring standard, and we need a reflection and the quality management. And normally we check our patients, we include in our practice a follow-up after 1 year, definitely, or 5 years and 10 years with the HerniaMed database. And finally, of course, we have to look for the next generation of surgeons, and we need a qualified education and training for them. That is my last slide, and right now, I would like to open the floor for debates and discussion.
Thank you, Ralph. That was really interesting. Can we just go back to slide 1, where you were talking about diagnosis? And a lot of people seem to struggle sometimes with hernias that they know they're there, they can feel the bulge, the GP or the primary doctor has felt it, but nothing's necessarily shown up on the scan.
I think I'm really critical because I strongly believe that in these cases, the symptoms are not really clear. And normally I would continue with diagnosis until I find the real reason for the pain. Because in my first slide, you have seen, of course, what are atypical signs for a hernia. I think we should stick on this diagnostic scheme that only if you have symptoms which are related to a hernia, you should do a hernia surgery. And I think normally, of course, it depends on the surgeon's expertise to do an ultrasound, but the ultrasound is, I think, in my mind, best possibility to check and to diagnose a hernia. And I think we have only in very obese patients sometimes the problem that the hernia might be not visible. But finally, of course, it's always visible for slim patients. And I don't believe, of course, these surgeons who, after 3 times doing a diagnosis and there was nothing found, and then finally they come up with a femoral hernia. I don't believe it.
Okay. What about some people have a scan with, do you call it the Valsalva movement or something? You put in pressure on, is that something that
I think that is definitely crucial. We do the ultrasound in standing position and in laying position with the Valsalva maneuver. And if you do an MRI or a CT scan, the patients are regularly in laying position and normally not doing any Valsalva maneuver. And for that reason, you can't see them when we don't give any pressure on the MRI during the MRI. You should speak with your radiologist and give them the advice that they should do a Valsalva during the examination.
Okay. So do inguinal hernia and femoral hernia, do they often get mixed up?
I think femoral hernias are almost a very rare condition. More in females, definitely, yes. We have roundabout in the database in Germany, we have roundabout 10 to 15% of femoral hernias in female patients, but we have only 0.5% in male patients. So for male, it's a very rare condition. For females, it's quite a bit oftener, but with the ultrasound, you can, I think, identify them if they have a size which is necessary to fix the hernia. If they have a small fatty tissue only in this, I think, femoral canal, that is quite normal. I think there is a lymph node inside the femoral canal, which is covering the femoral canal, the Rosenmüller lymph node, which is definitely not a pathology.
Yeah. So why is it more important for ladies to have the groin hernias repaired than it is for a man?
That's an interesting question because we can look back in the database and we could find or identify that female patients have definitely much less groin hernias, but there are much more emergencies. And the reason is almost the femoral hernias can have an incarceration even much higher or much more frequent than any inguinal hernia. I think that the reason is the gap is almost very small, and the content can be very large. And for that reason, of course, there is a higher risk for an incarcerated hernia. Indirect hernias are much more frequent for being non-reducible than direct hernias. I think there are a lot of differences between direct and indirect hernias. And that is something what we normally forget when we fix a hernia. I think one fits all, doesn't matter.
So we talk a lot about rehabilitation, and people have to be as fit as possible for their surgery. If you're having a tissue repair, I would imagine that's going to be a lot more important, is it?
I think not really. I think there is no difference in the prehabilitation or in the rehabilitation of these patients. I think when we, of course, give any advice after surgery, I think we have no differences. I would not make a difference between the prehabilitation and the rehabilitation after different types of surgery. Normally, of course, they are always the same. I think we gave always the advice, of course, stop weightlifting after surgery for almost 2 weeks or 3 weeks, and avoid very quick movements. I think you can do sports after 2 weeks almost. And normally we don't make any limitation. You can do whatever you like to do after surgery. That is possible, definitely.
Okay. What about before surgery? A patient, we talk about getting as fit as possible for your operation. Do you have a maximum BMI limit for a tissue-based repair?
Oh, yes. No, normally, of course. Technically, it is more demanding if you have an BMI of more than 35 or 33, something like this. That is something where I would say, okay, might be an endoscopic repair is even more ideal for that patient, because the outcome is quicker and something like this. But in very sportive patients, and in very young patients with small hernias, I would definitely give the recommendation doing a pure tissue repair instead of a mesh repair. Young patients, what is the limit of young? There is no limit. Normally, of course, we are all young, but finally, of course, and there is a huge variety in my mind. We have young patients with a small hernia, which could be an indirect hernia. And normally this is, for me personally, a good indication for doing a pure tissue repair. Young is a bit relative, but we have to keep in mind all the mesh implants have, of course, a guarantee to be stable, or might be 10, 20 years, 30 years. Nobody knows exactly. There's no exact study or not any evidence about any, of course, 30 years or 20 years follow-up after any surgery. And for that reason, of course, it's speculative to speak about the long-term effects of the mesh.
So what about at the other end of the scale? Do you have an age limit for doing the mesh-free repairs at the other end? No.
No, I think it's almost more the summary. Is the patient sportive? Is the hernia small? Is it an indirect hernia? I think, of course, an indirect has definitely, and that is something what we know from different studies from the Aachen University. They have a really low risk to develop a recurrence. And of course, once again, I would come back to who has the highest risk for developing a recurrence. That is mostly the direct or combined hernias. The direct and combined hernias have signs to have a connective tissue disorder. And that is something completely different to the young patients who has normally even more an embryonal genesis, which is an indirect hernia. They have no comorbidities. They have not a connective tissue disorder. In an age of 30 or 40, they have no connective tissue disorder in most cases. Not in all cases, but in most cases. And for that reason, of course, we can measure with the ultrasound the stability. We can measure the muscle. We can measure everything. We get a lot of details with the ultrasound. And I do it by myself since almost 15, 20 years. And right now, the instruments which are possible to use are very detailed, and you get a lot of information. It's very important to get an information about the content of the hernias. Like you can measure the gap, you can measure what is in, you can look for the inferior epigastric vessels, which is the navigation. Is it a direct or indirect hernia, or is it a femoral hernia? That is very crucial. And so for that reason, of course, we have, of course, as a basis, a very good and clear diagnosis.
Okay. What about we talked a bit in your slides about a foreign body feeling. If a patient is very slim, are they more likely to experience that, the Aegis syndrome and those sort of symptoms?
I think, of course, most of my patients who are requesting for a mesh explantation are almost young, mostly sportive. They had a previous operation which was not, in my mind, with a clear indication for the surgery. I think sometimes I miss some typical symptoms. And of course, so they get an implant. And they get, of course, a foreign body feeling. Very sportive patients are very sensitive with their muscles. And if you put something underneath, behind, or retromuscular, I think it has an effect. And if the mesh is huge, and normally, of course, in endoscopic repairs or even open repairs, we have a mesh size of 10 by 15 centimeters or even 12 by 17 centimeters. That has an impact. If you are very slim and of course, very sportive, you feel might be sometimes a pulling or even any, I think, tension in this area during sportive exercises. Mostly you can treat them with physiotherapy, because your psoas muscle is almost very close to this area, and the mesh is on top of the psoas muscle, and that makes a shrinking on this muscle or even an tendinitis in this area. And physiotherapy is almost very successful for them.
Okay, so what do you recommend for a sportsman's hernia, repair with or without a mesh?
I have a very clear opinion. Doing a sportsman's hernia, by definition, what is it? I have to ask you. I think it's not clear, Jackie. The definition, is it only a weakness of the posterior wall? Is it even a nerve entrapment? Is it a disruption of the posterior wall? I think it's not well defined in my mind, but in the majority of patients, we have a very good material and we can fix the hernia without any foreign body. It's the first choice.
Does it happen then that when you're having a mesh-free repair, you sometimes have to revert to mesh if the hernia is big? Does that ever happen?
I think, of course, if they have a recurrence, of course, so for that reason, the recurrence should be normally, as a first choice, treated with a mesh after surgery. We have one small exception, and that are, I think, young childs. If you get the previous surgery during your childhood, and normally, of course, nobody is fixing the hernia or even the posterior wall. I think they have only reduced the hernia sac, nothing else. They have not made any stitches in the posterior wall. And for that reason, of course, that could be an option also to do a pure tissue repair as a secondary operation. But if there is a collagen disorder or weakness as a recurrence after a previous pure tissue repair, then I would normally recommend doing a mesh repair in any way.
So in the UK especially, waiting times are long, and we talked earlier about, didn't you, that if you're not symptomatic, do you really need a surgery? Do you have any advice for patients as they, with watchful waiting, and how to live with the hernia if it's...
Yeah, I think, of course, if you have definitely no symptoms and you are feeling not really limited with your hernia, of course, for male patients, we could recommend doing a watchful waiting for, of course, for a couple of months. We know, of course, because of some studies, that most of the patients are getting symptomatic in a time frame of almost 2 years. But even young patients, healthy patients with very tiny and small hernias, of course, you can do it. Watchful waiting does mean, of course, not only waiting, also watching. I think, of course, and normally I invite them to come back in the practice. I measure, is there any difference in the size of the hernia after 6 weeks, after 8 weeks, after 3 months, after 6 months, depending on the size of the hernia and the symptoms. And of course, they get the advice, of course, if you have any symptoms during coughing, during weightlifting, or even pressing or laughing, then you should come back.
Okay. Do you think support wear like a truss or support pants, they help?
I have memories because my grandfather wears a truss, and so for that reason, of course, it could be helpful. Normally, I know this not with my own experience, only with my experience of my grandfather, and he told me, of course, it's not really comfortable. There is a kind of discomfort using a belt for a long time.
Yeah, we had the chat last month with Nicola from Vanilla Blush, and she was recommending a vest even for an inguinal hernia because they come right down to the groin and they can lift upwards and they can help. And so, like cycling shorts, they can be comfortable as well, a bit more comfortable for patients. Nicholas has just asked, why do you think in the UK we don't regularly offer non-mesh open surgery?
I don't know. I think it's definitely an issue. It looks like the reason is education, and normally, of course, there are not enough surgeons who are really dedicated on hernia surgery. I think I know a lot of UK surgeons. Of course, they do surgery or general surgery, colorectal, allergy eye, or whatever. And of course, beside they make also hernias. That might be a small difference to Germany. We have in all the big cities of Germany, we have dedicated hernia centers, mostly in a private basis, but of course open to everybody. And so they are dedicated, and like our own practice, we are 4 surgeons, and we offering all different techniques: tap, open mesh, endoscopic repairs, and finally the pure tissue repairs.
Right. Okay. So we always, as well, recommend that patients question the surgeons So for a tissue repair, I think, is it more important that you go to a surgeon who's done a lot more volume rather than somebody who does it once or twice a year?
Yes, definitely yes. A clear recommendation, do this. And normally ask your surgeon, what is your favorite technique? And of course, look for a different surgeon if you couldn't get enough information about this. It needs, of course, experience. And if you do it once or twice in a year, that's not enough, definitely not. Of course, I think we got a lot of requests from UK. So for that reason, I'm really familiar with this. We got a lot of patients from UK in the last couple of years. That's nothing which is surprising us.
No, because the
The
waiting times
reason
here are horrendous.
definitely, of course, there is not enough education in
Yeah.
this. Normally, of course, yeah, I think the colleges and the universities have forgotten this. And so my young surgeons get in touch with these techniques. They learn it. I have a very close collaboration with the Charité, which is a famous university in Berlin. And I think, of course, I'm responsible for hernia surgery for them. And they are, of course, almost 2-3 months in my unit. And they learn also a pure tissue repair, definitely. And normally after that, they can do it, not in all cases, but I think simple cases they can do by themselves.
What's your recommendation on local or general anaesthetic for tissue for repairs?
That's quite interesting. Of course, a local anesthesia is, of course, one environmental friendly. Secondly, of course, it's possible. It's not only feasible, it's possible. It's recommended in my mind in elderly people with a lot of comorbidities. And for that reason, I would normally do, instead of a general anesthesia, a local and might be a small mild sedation if needed. That is possible, and of course we do it in elderly people. Otherwise, after request, we do it. Normally, of course, our anesthesists are always on board, and of course they give any recommendation. And normally, of course, they have not any concerns to do a laryngeal mask. They normally not getting an intubation. Our patients also not in endoscopic repairs. They can be relaxed, and normally, of course, that is one option how to treat them very, I think, of course, mild and not really aggressive. But it's almost a navigation.
Yeah, it's good. We have a question from a lady who's had a bilateral inguinal repair and she's now expecting a baby.
Yeah.
Is delivery by a vaginal birth or a cesarean section more recommended after they've already had the hernia repair?
I got sometimes this question from, of course, different gynecologists. And I think in these cases, in young ladies, normally I would, as a first choice, avoid any foreign body. But if there is a foreign body, normally we have not any experience or any evidence that it will make any effect on the pregnancy. Might be you feel some tension in this area. That is possible because I think the mesh is under pressure. But there is no clear indication to do a C-section instead of a normal
birth.
Yeah.
Okay, and I think the other thing that comes up sometimes, and I think it's especially more for men, is that they're frightened to ask the doctors sometimes, can they still have sex? Well, yes, we say that's fine. You know, you might have to get a little bit experimental, but there should be no reason why not.
Normally, of course, I would give the recommendation you can do whatever you like to do. That is the first recommendation. Secondly, I would say normally, of course, it depends on the size of the hernia. If the hernia is really huge, of course, you will avoid any sex. But for a regular normal hernia and you have not a real huge pain during having sex, you can do it. No worries.
Okay.
And after surgery, it's my personal recommendation. It's like doing sports. And normally, of course, you can do sports after 2 weeks. Normally, if you are even doing more constant sports activities like running, cycling, swimming, you can do normally after 2 weeks. And then you can have also sex if you like.
Okay. So Miraz has asked, is it advisable to use mesh in all cases for an elderly patient?
No, not for all patients. Definitely, it depends on the size of the hernia, of the type of the hernia, of the comorbidities. And finally, of course, in my mind, we have selected patients where I would avoid a foreign body. We have a lot of autoimmune diseases which can develop an effect on foreign bodies. I think colitis ulcerosa is one of these topics. They are autoimmune diseases and they can be affected by whatever mesh foreign body reaction or inflammation. And normally, of course, they can develop after that symptoms or even an inflammatic increasing symptoms or whatever. I think that's
So if somebody is known to have quite a lot of allergies and they have a larger hernia, what sort of mesh would you use if it's not necessarily going to be mesh-free repair, if the hernia is a large hernia, maybe say like an incisional hernia, and they are prone to allergies?
I think, of course, if you have such a patient with, of course, an indication putting a mesh inside, normally, of course, for the open surgery, we would recommend using a lightweight mesh with a large pore mesh. In some cases, there is an option, but it's definitely not really evidence-based, that you can use a resorbable mesh. We have some experience with this, but the experience is not even that big. Of course, the companies are very pushy, advertising these new meshes, which are completely resorbable after 3 years or something like this. But I think, of course, there are not enough scientific basis or scientific evidence on this.
Okay. So Nicholas has asked, other than your physical examination to diagnose an inguinal hernia, is there a benefit of an ultrasound and CT? Well, we said that, didn't you? That you get a lot of information from the ultrasound, don't you? That you can measure the size of the defect and the hernia contents and the sac. So yeah, there is benefits to
Absolutely. I favor the ultrasound, which is simple. There is an easy access. You can get a lot of information. You can look for the opposite side. You can have a Valsalva maneuver. You can have the examination in standing position, in laying position. You have a lot of varieties and you can use them. And if you are, it's not very, very difficult. And normally if you have a superficial high high density ultrasound, then you can have a lot of information. So normally, of course, we have the color as well, so we can look for the vessels as well. That is really crucial, and a good diagnosis makes the operation much easier because you know in advance what have you to expect.
Okay. Another question, which I think you've already answered, is your advice for surgery different for tissue repair rather than non-mesh, rather than a mesh repair? And I think you've already said that it's pretty much the same, isn't it?
It's almost the same, of course. For the prehabilitation, of course, I give the advice: stop smoking, reduce the weight if possible. For the rehabilitation, it's almost, of course, quit in the first 2 weeks, doing weightlifting more than 10, 15 kilograms. And then you can start with some sports, running, cycling, swimming, a bit fitness, easygoing. And if you are really a weightlifter, of course, you should stop it for 4 weeks, almost 6 weeks, but nothing more. I think, of course, the recommendation in the previous or in the past was stop doing something more than 5 kilograms for 6 months. It's
not practical, is it?
No,
it's not practical. Okay, so again, Miraz has asked, if there is a scrotal edema post hernia plastic, should we drain it, or the scrotal support is enough? So is a truss enough with a seroma or edema afterwards?
I think, of course, for that reason, once again, the ultrasound is very useful, because normally you can look for the circulation of the testicles. You can have the information: is it a seroma where you can make a punction? Or, of course, if you have a huge scrotal hernia and you have, of course, the impression during the surgery that could have a bleeding or a seroma, you should use a drainage for 2 days or 3 days. And that is definitely useful. I think normally I give always to my young surgeons the recommendation: if you think you should do it, do it.
Yeah, okay. So Nicholas has asked, and for a first-time hernia, do you normally recommend open or laparoscopic repair? I think that depends on the patient, doesn't it? And
yes.
what your hernia is, and everything, a lot of other issues personal to you, Nicholas.
Yeah. I think, of course, with such an information, of course, we need the age, we need the sports activities, we need the size, the type of the hernia. We need, of course, any comorbidities that has an impact on the decision. And normally, of course, if I speak with my patients, I always offer, we have 3 different options. We have a pure tissue repair, we have an open mesh, and we have an endoscopic repairs. And then I explain what are the pros and cons in the different or individualized situation. And that makes sense. And of course, the informed consent makes, of course, the final say is the patient's view on this. And finally, of course, I would never convert anybody who will never have a mesh, and then finally you do a mesh repair during surgery. That is not fair in my mind. And normally, of course, we have to listen to our patients. They have an opinion. They are normally well informed, and they have sometimes much better information than we as surgeons.
So Jeff has asked, what do you recommend as the best recovery protocol after surgery? And this is something that there's not a lot of advice about for patients.
I think, of course, in the past, of course, we have very strict limitations after surgery. Right now, we are much more open-minded. And normally, of course, there is this opinion, you can do whatever you like to do and what you intend to do without having pain during this. And that is, I think, my personal recommendation.
That's something.
Normally, of course, you would avoid. The patient will do whatever they like.
Yeah, we tend to say, listen to your body. If it's hurting you, then don't do it.
No, don't eat a lot of pain medications. the whole day.
No.
Of course, you need them for the first couple of days. My personal recommendation is, of course, up to 1 week after surgery, you should use them frequently for the first couple of days, but finally, of course, after 1 week on request, on demand, and after that only on request.
A lot of patients find ice packs can
Yeah.
be as useful as anything.
Absolutely. Ice packs are very, very good. That is the cheapest pain medication you can get. I think icing 5 times a day, it's brilliant because normally, of course, it reduces the swelling, it reduces the pain, it reduces any inflammation, and it's easy.
Yeah, yeah, a bag of frozen peas or something.
So don't do it 24 hours
No?
because finally you get a bladder inflammation, but of course you should use it local, and then I really appreciate this.
Yeah. Well, Dr. Alf, it's time's finished. It's gone so quick.
I think it starts right now.
Yes, we've gone really quick, and everybody's saying thank you very much for your kind answers and your time tonight. It's been really interesting, and I think a lot of people are going to really benefit from our chat tonight.
Yeah, thank you. I will finish with a small secret about myself, because I have a hernia in my own personal perspective and career. And of course, I have fixed my hernia not by myself. That is possible. There is a literature that any surgeon has done on his own body, but I have selected a good and very experienced surgeon, and I have decided to use a pure tissue repair for my own hernia. And I'm really happy with this.
That's great. Okay. So yes, Nicholas has asked, he said, thank you very much. And it was very useful for him tonight. Is there a copy of the presentation available? It will be available later tonight on YouTube, and we'll post a link to it on the group.
Yes.
Okay.
Please
So
feel free to use it. Feel free to contact me. And might be, of course, Jackie, you can, of course, add my email address or whatever.
yes, yeah. And I think you are a member in our Facebook group anyway, aren't you?
Yes, definitely.
Yeah.
Yes.
Yeah. So thank you ever so much. It was an amazing session, and look forward to seeing you again soon. I think I'm going to see you in Oxford, aren't we?
Yes, I was invited to give a presentation during the British Hernia Society meeting in Oxford in November. I'm really happy, and what a prestigious meeting. And for that reason, of course, I'm looking forward to meet you again. And
yes, I will see you again in Oxford.
For, of course, inviting me, and it was a real pleasure for me and honor for me.
No, thank you so much. It's been great. Thank you very much.
Thank you.
Okay, take care and enjoy the rest of your evening. Thank you, everybody, for joining us tonight. Take care.
Take
Bye.
care. Bye.